I wanted to say a little about home blood pressure monitoring, which is something we've been working on for a long time. So a bit about what we found out before the pandemic, what's happened during the pandemic, and maybe a bit about what we can learn from that and what's missing, what guidance or evidence do we need, and how things might look in the future. So if we cast our minds back to before we knew what COVID-19 was, we'd just completed a survey of just over 5,000 women across the UK and asked them about what they did during their pregnancy and if they'd ever monitored their blood pressure. And what we found was that overall about 1 in 5 women were self-monitoring during their pregnancy. And looking at those with hypertension, about half of the women were self-monitoring during their pregnancy. And many of the women had decided to do this for themselves, and they were confident in their ability to monitor. So we asked them how confident they were on a scale of 1 to 10, and the median score was 9. So they were really confident and happy with what they were doing. But only half of the women who monitored said they shared or sometimes shared their readings. And this increased when we looked at hypertensive women to 79%, perhaps because hypertensive women were more likely to have been suggested to monitor their blood pressure by a healthcare professional. So what we can see from this is that large numbers of women are already monitoring their blood pressure, but perhaps not having that interaction with healthcare professionals about it and not sharing their data. We'd also done lots of pilot trials to look if self-monitoring blood pressure would be feasible and safe for women in pregnancy. So we looked at higher risk women, hypertensive women, postpartum women, and also done lots of qualitative and developmental work in the area. And all of this suggested that self-monitoring blood pressure would be safe for women and accepted. So we've recently completed 2 large trials of self-monitoring blood pressure in pregnancy, recruiting over 3,000 women. And although our analysis isn't complete, there were no safety concerns. So we can be confident that monitoring is safe, and also that it doesn't overwhelm antenatal care settings with additional work. Interesting, we did some work with healthcare professionals about their engagement with home readings, and there was a real range of views, as you might expect, ranging from a distrust that home readings could even be taken accurately and certainly wouldn't be honestly reported, all the way up to fully incorporating home readings in their decision-making and having a shared decision-making process. Interestingly, we've done an obstetrician survey, and we carried that out just before COVID-19 hit, and we've just done it recently, that again in September. And what we found that clinicians are really engaged with self-monitoring anyway, with 88% thinking that home readings had some sort of role to play in antenatal care. And that increased post-COVID to 96%, perhaps because of this rush to reduce face-to-face visits, and much more people have become involved in using it. So home readings being used to base treatments and decisions clinically was previously 33%, and this increased to 64%, perhaps not surprisingly, with the sudden use of home monitoring. So we were really lucky that we'd had this app we'd developed for our trials, and we'd worked really hard to try and to make that work really well, so women could monitor, get reminders, send in their readings to clinical teams, and these could be then used in clinical care. So we worked with a company called Sensign to develop this and make sure it's available to women. And this is now available freely across the NHS, along with other apps that a few other teams have developed as well. And we're really interested in this because this is an exciting sort of real life implementation. And we're hoping we can learn a lot about how this was used by women, by clinicians, and how you can implement this type of thing into practice. So we're collecting lots of data from the hospitals, the women, the clinicians, and also doing some interviews and ethnographies about understanding people's experiences of this rapid implementation. Something kind of important and exciting that happened at this time was there were also some guidelines for self-monitoring blood pressure in pregnancy, and this was the first time we'd had any guidance, or clinicians had any guidance about what to do, and these were published in the ARCOG. So the sort of before final thoughts, I just wanted to sort of note that it's not just blood pressure monitoring that's moved remotely. We know anecdotally that some clinics have additionally provided dipsticks for home urine testing, and people have occasionally noted that they've done that in the past as well. So I thought it was worth saying that we've recently completed some pilot work and also a large fully powered accuracy study looking at if pregnant women could accurately test their own urine. And all this work showed overall it seems to be feasible and acceptable to both women and staff, and that women were just as accurate as healthcare professionals in their reading of dipsticks. So women are willing and able to test their own urine. So overall, I think we've found that women can monitor and are willing and able to monitor their blood pressure, that home readings can be accurate. There are validated monitors available at quite low cost. And importantly, doing home monitoring doesn't seem to inundate clinics with lots of extra work. But I think there's a few questions still about how we should use it to provide good, effective care, and which populations and things we should do that might be of interest. So yeah, I'd be really interested in anyone's comments about what we should do, if we should go back to normal, how we might redesign care, and what kind of questions and guidance are still outstanding. So thank you very much. And just to say that much of this work has been led by Professors Rich McManus and Lucy Chappell, and there's an enormous team of capable PhD students and researchers and research midwives around the country that have been amazing, and of course the women that have taken part as well. Thank you very much.
Thank you very much, Katherine. Again, let me invite anyone to ask questions in the question and answer. I'm going to take Chairman's prerogative and ask you a question. I'm very much a big fan of this, and I remember 20 years ago trying to persuade people this was a good idea, and they were very much the attitude you couldn't possibly trust women to do this at that time. So I'm so glad you're doing this. My question actually is to do with our cradle device we've developed for low income with a traffic light system on it. Do you think there might be merit in simplifying recognition with a traffic light system, or do you think women are quite capable of interpreting numbers and acting appropriately?
I mean, all the work we've shown so far shows that they're quite capable. Whether that wouldn't be appreciated, I mean, I'm sure it might support both women and clinicians that, you know, there has been this flag, because there's not just an inertia to women not really wanting to come back into hospital, not necessarily wanting more medication, but also clinicians, as we see outside of pregnancy, there's a barrier to wanting to change medication. Oh, we'll just see what it's like if we take it again. We'll just see what it's like next time. So maybe that traffic light helps clinicians as well.
Okay, all right. Well, I think there is one question coming up. So Jenny Myers, I'm just going to read it. Thanks, Katherine. Do you think women are better at reading dipstick than healthcare professionals? Typical Jenny controversial question.
I think they're just as good. They seem, on the whole, you know, women are capable, competent humans. And the results we get show they're almost identical in their sensitivity and specificity and things like that.
Okay. And Fran Conti-Ramston's asked, have there been any barriers to monitoring of blood pressure or urine, for example, language or cultural issues?
That's a really good question, and it's something we're hoping to look at more and more to try and see if there's any groups of women who this would exclude or perhaps even benefit more. So there are groups of women who, for example, don't attend clinics very often, and actually home monitoring might be something that's good in those groups. It's something we want to look at more and more. Yeah.
Okay. And maybe got time for one more question. So Annabelle Frost, have you seen a difference in engagement and reporting with socioeconomic status and women and ethnic minorities?
We saw actually it's not particularly white British women who are the kind of key women who always seem to be involved. So our survey showed that there was really good diversity, and actually certain groups of ethnicities were more likely to be monitoring than the kind of main white British population, and things like deprivation didn't seem to impact it particularly. So most people have a smartphone. Most people are able to kind of use these things, and it appeared to be a problem, but it's certainly something we want to look at a lot more.
Sounds like you're going to be busy, Katherine. Keep up the good work. Thank you.